think I am live. I'm hooking up my headphones. Hang tight. Got to do that. Doc JP is here. I'm going to add him in. Uh-oh, it says Doc JP is unable to join. Let me see. Let me send a... Hi,
Hey,
how are you?
hey, how are you?
I'm well. I'm so glad that we're doing this. I've gotten
Yes.
so many comments. I've kind of advertised this a little bit and I've gotten tons of comments. So people are really anxious to hear about this. So I really appreciate you taking time.
Yeah, not a problem. Not a problem. Glad to be here. Thanks for having
Yes,
me.
you're welcome. So this is Dr. John Patton. He is a regional anesthesia and acute pain management fellow at Cedars Sinai in LA. So tell me, what does that being in that fellowship as far as regional anesthesia and acute pain, what does that mean for those that may not know?
Yeah, so let's just go back a little bit here. So I did my anesthesia residency at Stanford. That was 4 years
Mm-hmm.
of residency. So I am actually done with anesthesia.
Mm-hmm.
I'm now doing a specialization or furthering my training in acute pain medicine.
Okay.
So I took my boards, my written boards in 2020 in the middle of the summer with everything going on. I
Go.
passed. I passed.
Yeah,
I did
yay.
well. Yeah. I now have the opportunity to sit for the oral boards, which we'll see when that's going to happen because of the
Yeah.
pandemic. It may be into this year or next year. But
Mm-hmm.
um, my training in acute pain medicine is 1 year. So
Okay.
essentially, what we do is we offer nerve blocks for surgeons either before or after surgery for their patients who would be good candidates for nerve blocks. We offer nerve blocks for patients who come in through the emergency department who may have trauma. Let's say they have rib fractures or some broke their hip. But we also do neuroaxial anesthesia, which we're going to talk
Mm-hmm.
about a lot today, which is
Yeah.
very much so, very commonly used on the labor and delivery suite. So we
Mm-hmm.
do epidurals, we do spinals, and a number of other things. And not just that. I mean, it's not just procedures. We also offer acute pain management services on the wards as well for patients
Yeah.
who are chronic pain patients who are coming in with acute flares.
Yeah, yeah.
So,
So we have an OB anesthesia fellowship where I work, and
right.
I is it kind of the same thing maybe, or is it
No, it's
more
actually
focused on
different.
it's different? Okay.
Yeah, so I was going to say, as an anesthesiologist, depending on where you train, where
Mm-hmm.
I train, we had a significant amount of exposure to OB anesthesia.
Yeah.
And a lot of the heads of SOAP, which is the Society of Obstetric Anesthesia and Perinatology, they were actually at Stanford at the time when I was
Okay.
there. So I got to train with a lot of them,
Nice.
which was great. So after anesthesia residency, you have the opportunity to work with laboring individuals, but usually in an academic setting,
Mm-hmm.
more so than in the community setting, even though the community setting are starting to hire more OB anesthesiologists.
Yeah.
You're going to find more OB
Yeah.
anesthesiologists in the OB
Yeah.
wing of an academic institution. So
Mm.
um, I'll be able to do some OB depending on which job I ultimately end
Sure.
up choosing after fellowship. But at Cedars Sinai, all of the OB is done by OB anesthesiologists. So we come in to
Yeah.
help if they need us to do regional nerve
Gotcha.
blocks for postpartum.
Yeah.
Um, but usually all of the intrapartum and postpartum work is pretty much done by the OB anesthesiologist for the most part.
Yeah. So today what we're going to talk about is, and the reason why I asked you to do this is because you've done a lot of education and you do a lot about epidurals, and that's how I first
Right,
found you actually on
right.
TikTok. Dr. Patton's on TikTok at DocJP3 and also on Instagram here, and I'll put that in the notes for the video. But first, we're going to jump right in. We're going to talk about the first way that we can control pain during labor delivery, and that's going to be starting with one of the least invasive, I guess you might say, and that's just IV pain medications, or what we
Right,
refer to as parenteral, which means
right.
intravenous. So explain a little bit, I will start by saying what is available on each labor and delivery unit depends on that labor and delivery unit. There's my labor and delivery unit might prefer certain IV pain medications different than Dr. Patton's. Every unit's different, but they kind of all do the same thing. So explain a little bit how those IV pain medications might work or what the options might be.
Yeah, so there's been a lot of research in this area in terms of what's safe for mom, what's safe for baby, in terms of IV pain management. For the most part, the IV opiate that's used pretty commonly at all the places that I've trained or have been at least is fentanyl, which is
Mm-hmm.
a short-acting
Yeah.
opiate. Sufentanil is also used, and also remifentanil. Now
Mm-hmm.
they're all like cousins of
Yeah.
fentanyl.
Mm-hmm.
Without going into the weeds, we don't need
Yeah.
to go too
Mm-hmm.
deep into it. But usually these are used because they're short-acting, they're safe, and that you don't really see any concerns in terms of issues with baby coming out and having reduced APGAR scores,
Mm-hmm.
having issues with breathing and whatnot. That being said, for the for the IV opiates, usually what we do is we administer them up into a certain time point, because what we don't want is for a baby to have any difficulty breathing and or not breastfeeding afterwards. So usually if, let's say mom's getting IV fentanyl, wanted to try that, before maybe trying epidural or some other form of analgesia, we won't administer it if we believe mom is, let's say, about an hour out from delivery, because we don't want the opiates to linger in the baby's bloodstream, because the baby's elimination of drugs is going to be different from mom's, for example. And so the opiates can linger for a little bit longer in the baby if we give them too close to delivery. So typically we'll offer, at Stanford, for example, we were offering 3 doses, or let's just say 3 doses of fentanyl. And so mom would have three doses that she can, receive of fentanyl. It doesn't really, unfortunately, last very long. It's not quite effective in terms of reducing pain scores. It's just not a complete way of alleviating pain or the contraction pain. And it does have some side effects as well, which, we can go over, notably nausea, vomiting, some itching, can make you feel a little groggy or sleepy. But like I mentioned, it is a short acting opiate. So it's eliminated pretty quickly. So
but by mom, but you mentioned about
by
baby.
mom.
Not
so much by baby.
About baby. And then, earlier in labor, there's some things we will give things like Nubane, Stadol, which are a little bit longer acting. And what you might hear if you do get that medication is we might say the baby's heart rate tracing might get a little flatter. But that's because the baby's getting the opiate. And that's one of the things that we see. So we know, well, did mom get this pain medication? Yes. So now we know why the baby's tracing looks that way. And that's another reason why we don't want to give it too late in the labor game. Or if we think you're progressing really quickly, we may want to hold off, because it does cross, into baby, and baby can be born what we call depressed. Meaning they might have a little trouble starting to breathe on their own. They might have a little trouble latching on because they're sleepy, in other words. So we're not trying to be mean, I promise. We just want to make sure that we don't have baby born, we want the baby to be born vigorous, in other words.
Yeah, and there are some instances where neuraxia, which we can talk about, epidurals or spinals, are just not great options for mom, and we can go over that. But so, for example, Stanford, when I was there, we were using remifentanil, bolusing or PCAs, and so the thing with that though is if we're going to use these kinds of meds, and let's say we're going to use them pretty much up until delivery, then we know we're going to have the pediatricians on standby. You may have to have NICU on standby, because again, we want to make sure that the baby is breathing, and that, we're being mindful of the fact that baby may take a little bit longer. Now, the baby, we metabolize, again, I won't go into the weeds here, but we metabolize the remifentanil differently than we metabolize the fentanyl. So actually for the baby, the babies actually can metabolize the remifentanil as well, because it's not metabolized the same way as fentanyl. So in that situation, that's the reason why they're okay with using remifentanil for maybe a little bit longer than they would use the fentanyl.
Well, back what you were saying, we can talk about it now. There's a whole list of reasons why there might be, I'll give low platelets for one example, why giving an epidural or spinal for labor and delivery purposes is not recommended, because there's a medical condition with mom where we don't want to do that kind of block or, do anything like an epidural or spinal. So we might treat her with IV pain meds. When we do that, or with anyone really, we let the pediatricians know, hey, she just got this medication how long ago, because they're going to ask us. So it's important that we let them know, because if we don't communicate and the baby's born and it's sleepy, they may be trying to figure out why, when really it was just because she got a medication. So if you are one of those persons who, for whatever reason, an epidural or a spinal is not in the cards for you, you might want to do, I'm sure you guys do this, at our center, we do anesthesia consults, where they can talk to them ahead of time. Hey, I can't get an epidural for whatever reason. What are my options? I think that's underutilized way too much, and I highly advocate for that, because I think it's a good way for patients to get education before the day that they come in for delivery. Would you agree?
I totally agree. I mean, especially for maternal fetal medicine, for our MFM colleagues, there's oftentimes where we'll be brought in very early in the the laboring process, or well before it even get to that point, because mom, let's say, has preeclampsia, or she has pulmonary hypertension, whatever it may be, something that actually would be something we'd really want to know about, so that we can actually strategically plan all this out before even mom, gets to the labor and delivery suite. And, some of the contraindications, again, you mentioned coagulopathies, maybe they have low platelets, if you have an infection, or there's some concern about your blood volume being low, or you have high intracranial pressure, meaning the pressure in your central nervous system, the brain and the spinal canal and whatnot is too high for us to place an epidural. Or maybe your curvature of your spine is so much so curved where it's like we try to do the epidural and we're not able to get the epidural in because of just, anatomical variation. So we'll have to, try, plan B or C in terms of trying to get mom more comfortable. So
yeah. So if you've had back surgery, if you've had,
let us know.
The earlier you let someone know in your pregnancy, the better. That way a plan can be made. And there's nothing better than having that plan already in place than when you actually come in labor, we try to scramble to figure out what to do for you. So, we could definitely do that.
And I'll say, the really nice thing about letting us know is, there's a way for us to, for example, use an ultrasound machine. If it's early on, let's say you're not at the point where you're like, 7-8 centimeters dilated, this multip, you're on maybe 2 or 3, and we're like, okay, we don't have a lot of time. If it's early on and we have a lot of time, we can ultrasound the back and we can mark out exactly where we think we should go and really strategically plan it out without having to even say, you definitively want the epidural. You may be on the fence, but we can still go through the process of making sure that we take a look at your anatomy and figure out exactly what we would do if for whatever reason you change your mind, because it's always your choice, always your decision. We're not here to force epidurals or spinals or anything on you, to be honest. Whatever you want in terms of your laboring process is up to you. Now, we're just consultants, we're advisors, we're your coaches, we'll be there rubbing your face down. If you're having to have a C-section and you're sweating, we'll hold your hand. If dad's not able to hold your hand because of or whomever is not able to hold your hand because of COVID restrictions, whatever, we'll be there with you. But at the end of the day, whatever you want to do in terms of your laboring process from a pain management standpoint is up to you. But we can do these things like mark the back and do all these other things to help us know where to go, so that when the time comes and you do change your mind or you do decide, I want it now, which often happens now. Okay, it's like, all right, here we come. We'll have a better chance of success, more quickly and safely.
Well, and along those same lines, you might find when you go in for labor and delivery that it's standard to get an anesthesia consult. And I've had patients say, well, I don't want anything. I don't need that. Well, it's not just that. Things may change. You might end up needing a C-section for whatever reason. You may change your mind. There may be reasons why anesthesia needs to get involved. So them getting to know you while you're there, you're not in active labor. They have their note on the chart. You've been assessed in case you need them for some reason. It doesn't mean you're definitely getting an epidural. It just means they know you and they're not going to be surprised if they're called upon at some point in your labor process.
And I mean, we all work in shifts. So let's say, there's a day anesthesiologist and a night anesthesiologist and you come in the afternoon. It helps to know that you've already been talked to, so that when the night team is going through the list and, someone says room number 4 wants an epidural, you can say, okay, we're looking at the chart. Room number 4 has already been talked to. So all I have to do is introduce myself and bring all the equipment in and we can go ahead and get started. It definitely helps to have the discussion, whether you decide to or not. It just again, it helps with workflow and everything. So
sorry, I wasn't expecting this.
No, it's okay.
It's my huge puppy here.
Okay, I see a question here really quickly that just goes along with what we're saying, because I had a microdiscectomy at L5-S1 7 years ago. Could this affect my ability to receive an epidural? So we actually place the epidurals. We usually strive for a level below the L2 vertebra. And that's because the spinal cord, ends around L1 to L2. And so we don't want, obviously, if we're doing spinals or, epidurals, we try to avoid having any interaction with the spinal cord. So we actually have a few spaces above the L5-S1 interspace where we can actually, hopefully, place the epidural. Now, that being said, there are certain neurosurgery, certain surgeries that people have that sort of impact the dura, or for lack of a better word, or make it so that it could be challenging to get the spread that we would like. So it sometimes can be challenging, and it's a great question, but an L5-S1 microdiscectomy probably wouldn't preclude you from being able to get an epidural. We should be able, whomever does your epidural, if you need one, should be able to do it.
Yeah, if you've had any kind of spinal surgery or anything, oh my God. Hold on just a second. Renee! Are you there?
I'm here.
Okay, sorry. I don't know. It got paused. It wasn't because of the dog. That just happened. Yeah. So I forget what we were saying, but anything with the spine, it's better to let your doc know early in the pregnancy, because they can get records
Yes.
especially if you had it done at a different institution. And that's invaluable for anesthesiologists to have that rather than trying to play a guessing game as to what exactly you had done.
Right.
Yeah. Okay. So moving on to, let's talk about epidurals and spinals. Let's first talk
Yeah.
about epidural. Well, tell us, just break it down. What's the difference between an epidural and a spinal? Meaning what they do, how they're placed, and who usually gets an epidural versus a spinal.
Yeah, so let's start from vaginal delivery and cesarean section. We'll go with the vaginal delivery first, or let's just say you're in the labor and delivery suite. You're not a scheduled C-section, okay? So you're in labor and delivery. You walked in and you're hoping to have a vaginal delivery. Either you're toe-lacking, you're trialing labor after cesarean section, or you're having just a straight vaginal delivery, okay? So in that situation, what we would do is we would come in and have a discussion with you about what your options are. Now, there are 3 different neuroaxial techniques that we basically offer. Either an epidural, a CSE, which is a combined spinal and epidural technique, or we would offer a spinal. Here, okay, good. So
No,
epidural combined spinal epidural technique, or a spinal, which would be a single shot spinal. Okay. Now we would offer these techniques or these different neuroaxial procedures depending on where you are in labor. Usually, if someone is earlier on and the pain is okay, and we're thinking that we don't necessarily need to have a quick and immediate decrease in pain. We can just offer an epidural, and the reason why I mention that is because the epidural it takes a little bit longer than a spinal to set up.
Yep.
We're actually injecting the medication, the local anesthesia plus the opiate, which we can go into that, into the space that is epi before the dura. Right? Without going into the anatomy too much, but we're not actually going into the dura. We're not penetrating dura. We're actually trying to go into the space right before we get to the dura, right? And this is a space where the nerves come off the spinal cord and they kind of traverse out and through. We're catching the nerves out of the spinal canal, okay? And so in that situation with the epidural, we would mark out our landmarks. We would have you sit down. We would palpate your hip and try and get to the iliac crest, which is the top of the hip bone. That's actually the area where L3, L4 is. So again, we're trying to be below the spinal cord. So it's usually a good way for us to hopefully ensure that we're below. Although some people's anatomy is going to be a little bit different, so the hips are going to either be higher or lower depending on who you are. But nonetheless, it's usually a safe bet. So once we find that, we use our TUI or our needle. We advance until we get into the epidural space. We inject either saline or air just to confirm that we're there. And then we thread in a catheter, which is sort of like a angel hair pasta or spaghetti, right? That catheter sits in that space and will either bolus the epidural either continuously over the course of an hour, but more commonly now we're actually doing intermittent bolusing. Where you're getting a bolus either every half an hour or an hour so that we can keep the space filled. And then the patient, the laboring individual, is also able to administer additional medication by a button, which is a PCEA off the pump, so that we can actually increase the spread as well. Because pain relief comes down to the amount, the concentration of drug that we're using and the amount of drug that's in the space. So how filled the space is and how concentrated the drug is that we're using. And so that's the epidural. The epidural sits, again, before the dura. So we're not going into the dura. It sits before, and we're basically just coming into a space. If this is the dura and this is the spinal canal on the other side, we're coming into this space right here where the catheter is going to be threaded up. Sometimes it can be down, but we hope it's threaded up and it's straight in the middle so that we get equal pain relief on both sides of the belly. Okay, when we're doing a spinal, we're actually taking it one step further. So instead of stopping in this space here, where we're going to thread the catheter and we're not trying to actually penetrate the dura. For a spinal, we actually are trying to penetrate the dura. Now, this is usually used with the TUI and or sometimes it could just be straight spinal where we're not using a TUI. It's just an introducer needle, and we there's a very long, thin needle that is advanced until we get to the dura. We feel it pop through, and once it pops through, we see the CSF coming out, which is our confirmation that we're actually in the right space. The CSF will start coming out, and once we see that, we inject the numbing medicine, much lower amount, because as you go through, so you need more IV pain medicine, then you need epidural pain medicine, then you need intrathecal or medicine that goes into the spinal canal. So much less medicine is necessary for a spinal than is needed for an epidural. So once we get in, we push that medicine in. Now that bathes the nerves that are coming off the spinal cord, and you almost get instantaneous pain
Yeah.
relief, very, very
Mm-hmm.
quick. You
Mm-hmm.
also can get a quick drop in blood pressure.
Yeah.
You know, there's many other things. It's hard to titrate that amount of medicine because usually we don't leave catheters there. In some instances we do, but usually we don't. So once that medicine goes in, it's kind of an all or nothing thing.
Yeah. Yeah. Yeah.
Right. And so usually that spinal, if let's say mom we think she's only an hour away from delivery, her pain is really, really bad. We don't really have enough time to place the epidural, but we do think that a spinal would be adequate enough because we believe multip, you know, mom's likely to deliver within an hour. We'll do that without having to place an epidural catheter, and we'll just hopefully everything will go well, baby's delivered, and that'll be worn off in an hour. The epidural will last as long as we keep the catheter in there, right? It takes about 15 minutes for the medicine to set up. Once it sets up, we can decrease or increase the dose that's coming through the pump. We also can increase the concentration by adding more medication in as well. So we can do a lot more in terms of troubleshooting the epidural to get mom more comfortable or less in your situation, right? When we need her to feel more, you know, be able to push and all these things, we can decrease it or turn it off, pause it. But that catheter, once it's removed, then the body will metabolize the drugs, and eventually you'll start getting, you know, some sensation back, and the medicine will wear off. So those are the three techniques. The last one, as I mentioned, the combined spinal epidural technique, that's using the epidural TUI, which is the needle, and we just put the longer needle inside and we inject the medicine into the spinal canal, and then we take the spinal needle out, and then we thread in the catheter in. So those are the three techniques. So that's usually what we do for labor. For women who are laboring on the floor and hoping to have a vaginal delivery. A C-section is completely different. If it's a C-section and it's a scheduled C-section, and you know mom's not, you know, there's not an urgent or emergent need to, you know, for you to get baby out quickly. Usually what we'll do is, if we're thinking that this is not going to be complicated, we'll do a spinal, because usually our OBs are pretty good and quick in terms of getting baby out. So the time that we would need to have, you know, the duration of action of the drug would be such that mom should get enough relief, and be able to actually have a safe, you know, procedure without having to experience any discomfort. And we also offer a little bit of morphine as well, to increase the pain, you know, to help with pain management afterwards. We do that, or we can do an epidural for that as well, for C-sections, whether it be scheduled and or mom trial labor and now is in need of a C-section. So that's the benefit of having an epidural catheter in. If you're hoping to have a vaginal delivery, if for whatever reason you do need to have a C-section, which you can obviously talk about what those reasons may be. It's not because of the epidural, but if you do need to have a C-section, we can use the epidural for the C-section so that you can be awake, and we can talk about why that's important.
Yeah. So we'll talk first a little bit more about with the epidural. As Dr. Patton just said, we use epidurals for people who are anticipating laboring, whether it be, you know, vaginal delivery or attempting a trial of labor after cesarean. You know, we get the question all the time, how soon can I get it? That's really a decision that obstetricians usually make. For me, I don't have an opinion. I'm not going to make them wait till 6 centimeters, 4 centimeters. It's when they want it, because there's really no data that says that it slows down labor. There was some thought at some point that it did, and there was a push to wait till 4 to 5 centimeters. That hasn't been proven. So when you want the epidural, you can get it. It's not going to alter the progress of your labor. On the other hand, and you can answer this, there are some times when a patient gets an epidural and then they relax and they progress really quick. Correct. And what some people think is it's because of the epidural, and whenever you progress quickly in labor, the baby's heart rate can drop. It's whether you have an epidural or not. Okay, so it's not because the epidural is making the baby's heart rate. It's because you're just progressing quickly, and it can happen with or without an epidural. So yes, that can happen. And we, you know, sometimes we'll go in and she's 5 centimeters, and you'll see baby's heart tracing drop. You go check her, she's 9. That's just from rapid descent. With or without an epidural. But sometimes after an epidural, they can have a drop in heart rate too. What are some of the reasons that might happen?
Yeah, so again, you know, we are much more cognizant, not to say that we weren't 20, 30 years ago, but we actually use a lot of data, and like I mentioned, like the whole field of OB anesthesia has evolved over the last 20, 30 years, very much so. You know, maybe 20, 30 years ago, we were using a lot more, let's say, local anesthesia, or, you know, not using any opiate. And we, you know, now we're using a combination of the opiate and the local anesthesia to reduce the amount of each that's needed, right? So we
Okay.
can actually decrease the amount of local that's needed, and we can decrease the amount of opiate that's needed to hopefully avoid some of these complications. Now, of
Yes.
course, if you're doing a spinal and mom's blood pressure drops, significantly, low blood pressure will decrease actually flow to the placenta as well, and can decrease blood flow to the baby, which would decrease oxygen to the baby, and that can cause non-reassuring fetal heart tones and whatnot. And so we actually end up having situations sometimes where we have to obviously treat mom's blood pressure with blood pressure medication or with fluid. We anticipate this though, right? So it's not like we're some quote unquote surprise. We anticipate that us giving a medication in the intrathecal space or doing a spinal could cause the blood pressure to drop. So in that situation, we try to, lay mom on her side and do all these different things that we can do. And we already mentioned, the opiates that we're using, we're not using, opiates like morphine or Dilaudid, more so now than we're using fentanyl and remifentanil and sufentanil because they're shorter acting and they have less, consequences in terms of baby's ability to breathe and APGAR scores and all the things you mentioned, heart rate and whatnot. So we're using science. It's hard to do studies, especially randomized controlled studies for obvious reasons on the OB population and with newborns. It's just not going to ever really happen, from an ethics standpoint. So we have to use a lot of, retrospective data or follow them prospectively without actually having to do a randomized controlled trial in the way that we normally do it. And so we know that these drugs are very, very safe in terms of fentanyl and the local that we're using, very, very safe. But every once in a while, like you mentioned, there are other reasons for these as well. But you may see someone get a spinal and they may have a decrease in blood pressure or maybe their heart rate will decrease and that can decrease flow of to the placenta, which would obviously impact flow to baby. And so in those situations you could in theory, even though it's very, very rare, you could in theory see a situation where after getting a spinal or a CSE that baby's heart rates were to drop.
So one of the other questions I get a lot about epidurals is, I already talked about one thing you might want to do with your obstetrician is talk to them. Do you have certain preference on when you want me to get an epidural? If I want an epidural, do you want me, talking to your obstetrician about that before you even go into labor is ideal because every obstetrician is a little bit different. And some of them want you to wait a little bit longer. And if that's the case, you can ask why, but that way you won't be surprised. The other thing about epidurals is sometimes patients, it doesn't work.
Correct.
Or they get what we call hot spots.
Yep.
Or you have to do try multiple attempts. What are some of the reasons why the epidural might fail, or you might have to try again, or they might get a hot spot?
Yeah. So 10% of the time, it seems like a high number, right? When we talk about risk, the biggest risk is actually the epidural won't work. And that's actually something that I think would be reassuring. Now, to someone who's obviously in pain and in labor, they don't want to hear that. But that just means that all the other risks, the ones that are quote unquote really scary, are very, very rare, right? So 10% of the time they don't work. And it can be for any number of reasons. Let's see, the epidural catheter is going into the back and we're hoping it's going straight up, but it can veer off one way or the other. That's one reason why it doesn't work, right? So maybe you have a situation where the epidural is veering off to the left. So the left side of the belly is much more numb than the right side. And so you're starting to feel some contraction pains on the right side. And so we'll have to troubleshoot the catheter, try and either pull it back a little bit to hopefully pull it and make it become straight again, or we have to replace it. Because priority number one, even more so, and I say this, again, I want to reiterate that your safety and comfort, laboring patients or laboring individuals, priority number one. But actually, priority number one is making sure we have a good working epidural, because if for whatever reason you need to have a C-section, I have to be able to trust that epidural.
Epidural's going to work,
If I can't trust the epidural is going to work well, then it's going to be, a situation where we're going to have to obviously go down the potential road of having to have a general anesthetic, which we can talk about. So if I can assure myself that the epidural is working well, that gives me reassurance when if and when it's time to do a cesarean section, that I can use it. That's number one. Also, some people's anatomy is just very different, right? We already mentioned, some folks have a much bigger curvature to their spine. You may have had spine work done. There could be other anatomical variations that are causing the spread of the local to not actually bathe the nerves in ways that we want. And actually, so when you're looking at the first stage of labor, we're trying to get local anesthesia from the T10 to L1 level of the spinal cord. When you get to the second stage, when baby drops into the vault, we're actually now needing to bathe the sacral roots. So if you have a good working epidural, now all of a sudden baby drops down and you're in a second stage of labor and you're having more pain, it doesn't necessarily mean that the epidural is not working. It may mean that you need more local. I need to come in and I need to bolus that bad boy to get more local in there so that we can get the get you more comfortable, because those sacral nerves, those sacral roots are larger. And so we're talking about now having to bathe the nerves that supply the perineum and the vagina and other areas, right? Because the baby's now dropped down, and so you're having a significant amount more discomfort. Usually that's indicative by mom saying, I have a lot of pressure or pain down low, I have to poop. So we may not be able to actually bolus too much, because you may say, well, I don't want you to come in. I don't want you to come in.
Exactly. But we'll say this, you know, the thing about the epidural is when it comes time, you don't want to be completely numb. Because what happens is there's been times where the patient, I can touch their bottom, the baby's right there, they don't feel a thing. And then they try to push and they're wasting all this time pushing, the baby's not doing anything, the baby's not moving because they can't feel. You want to feel something. I'm not saying you need to feel 10 out of 10, but you want to feel something. You want to feel that pressure so you know where to push and don't waste your time or your energy. Okay, so there's been times where I've had them back off on the epidural. Okay, I'll say, call anesthesia and, hey, can we back off a little bit so she can feel something? So that's a good thing about the epidural. They can work with the pump. They can, slow it down or even shut it off temporarily. And that's a thing that can work. There's also been times where a patient might come in pretty active and she really wants an epidural. She's, say, 6 or 7 centimeters. And I'll say, we can get it in, anesthesia can get in it, but I say, but don't dose her up completely, as if she was in the very first beginning of her labor. Just give her enough to get her through. And, that's where the teamwork comes with the obstetricians talking to the anesthesia so they know what to do. And there's a lot of finagling they can do. They have a lot to do these types of different techniques to give us what we need for the patient. So teamwork is always essential between OB and anesthesia. Right.
And again, like I mentioned, so things are really different than they were 20, 30 years ago. We actually call them walking epidurals. Now, that just means that in theory, there's not a dense motor blockade. So you actually could walk. We don't let you walk because we don't want you to potentially fall, because it could be weakness. So usually when a patient has an epidural, they're going to have a Foley catheter, a urinary catheter, because we have to help you void. We're not going to allow you to walk, especially not without assistance. You have to have like your L&D nurse with you, or someone with you to ensure that you don't fall, because that's the last thing anyone wants. But we decrease the amount of local, and we decrease the amount of opiate that we're given, again, because we're trying to find that happy place between alleviating your pain, but ensuring that you can still feel the pressure that's necessary so that you can coordinate pushing with the L&D team, your OB or your nurses, so that you can actually get baby out.
It's important that you can tell where to push, because it's not good to waste a lot of your time pushing and you don't feel anything. So we use anesthesia a lot to say, hey, let's do this and try this, and you got to get the baby out. One thing I wanted to talk about, and you have educated a lot about this on your social media, and that's about, and the reason why I'm bringing this up is because about epidurals. You have educated a lot about health disparities and racism in medicine. And the reason why I want to bring this up is we know that healthcare providers are less likely to respond to the needs of Black women, especially in obstetrics. And one of the stats that we use, or we know about, is that Black women are about 22% less likely to get an epidural. So that's alarming. And it's something that we have to address and acknowledge. I just want your opinion. Do you think it's because healthcare providers are not listening? Do you think it's because of a lack of trust on behalf of Black women about getting the epidural, or do you think it's a combination of both? And how can we make that better?
Yeah, well, I mean, this is an issue that we've been dealing with for 400 plus years in terms of health disparities. And, let's be honest, it's rooted in, unfortunately, systemic racism. The healthcare industry, like all other industries, we've had our demons as well, in terms of how the Black and brown community has been treated, and how we've been subjected to pain and trauma from the jump. I mean, if you just look at the father of gynecology, a lot of the techniques that he perfected on slaves without their consent, without anesthesia. So this is nothing, we're not proud of these things. I'm not happy to admit, say these things. It still is a big reason for why there's mistrust in the healthcare community. Because I mean, just over the course of time, there's been, occurrence after occurrence of things like this that basically just make it so that the Black and brown community, is not adequately cared for in a way that is equitable to our Caucasian colleagues. And frankly, people don't really, appreciate, they don't properly quantify and understand our pain. You know, not everyone's pain looks the same. There's obviously bias. You know, there's issues with bias and how we see and treat patients. I mean, you look in the emergency department, the literature there, my buddy Atala Brown and I, we talk about all the time, when a patient comes in with pain, you know, depending on whether or not they're black or white, their experience can be vastly different. You know, one is viewed as drug seeking, or one is being denied, you know, medication, and others is not, you know. And so I just think that we have to understand that, like, you know, when it comes to pain management, a lot of the scores and whatnot that we've created with a Caucasian standard. I'm being honest. So like, you know, the expressions that we use, the language that we use and whatnot, the way that we describe our pain, the way that we describe our discomfort is not going to be the same for everyone, right? I could be in 10 out of 10 pain right now, but I can also still have a straight face. I don't have to have that agonizing, you know, beating sweat look to myself, you know, like we see when we look at the charts and whatnot. We just have to be, you know, we have to just build trust. We have to be able to communicate with our patients and let them know, you know, what our goals are and what their goals. Yeah, they have to be able to obviously express their goals as well, so that we can actually reach people where they are. And it's a shame. It's, you know, it's not a good thing that, you know, obviously a laboring patient can come in and be in agony and not receive the pain control or the epidural, whatever it is that would be offered, that would be offered to anyone else, that she wouldn't be able to receive that. And that's quite honestly, you know, it's maddening and saddening, you know, but at the same time, it just shows that we have a lot of work to do. I think we need to make sure that, you know, we're obviously checking our own personal biases. We have to make sure that we're trying to be equitable in terms of how we treat folks, not just saying that we want equality, but like we want equity, right? And we also have to make sure that that we don't assume that Black patients are lying or uncomfortable, or, you know, they're not telling us the truth, quote unquote. The assumption that, like, you know, that person can't be in pain. We have to go into every situation, you know, with an open mind and understanding that, like, the patient truly could be experiencing whatever it is that he or she is saying she's experienced, without coming in with our you know, preconceived notions or biases. So that's I don't know. It's a very tough one, because in this space, you know, it's not just that. I mean, I'll just go off on a little tangent here. What concerns me a lot, and you could speak on this because I'm not an OB, is the fact that our Black and brown females are still dying and at a higher rate than others. You know, in terms of childbirth, you know, the morbidity and mortality for Black and brown people, and it has nothing to do with socioeconomic status. I mean, you just look at Serena Williams and Beyonce and their experiences. You know, high socioeconomic status, high education does not necessarily make you any better off than those who are in rural Caucasian areas, you know. So it's just all these things are quite alarming to me.
Well, I think that we're getting more information and we're spreading awareness, which I think is great, but you have to put that into practice.
Correct.
And what this is an anesthesia talk, but I'll just go say my opinion. But I think it's important to talk about this because for two reasons. Providers have to be willing to acknowledge there's a problem, and the problem might be with you. And until we're able to do that, it's not going to change, no matter how much awareness we put out there. As long as you think the awareness applies to somebody else, they need it, it's not going to help. We all have to understand that we're all complicit in this to some degree, no matter how we think we feel or how we are treating our patients. Right. The other thing is this: if you are a Black or a brown woman or individual who is pregnant, you can find providers like you. You can find people that you trust. And if the person who's taking care of you does not give you enough to trust, then you find somebody else. You have to be heard. It's okay to have an advocate. It's okay to have somebody in the room. Even if they can't physically be there for a pre-op appointment, they can talk on phone or talk via Zoom. There's things that we can do right now, especially in COVID times, to have that advocate there with us. It is a scary time, and with this whole maternal mortality thing is another conversation that I would love to have with you at one point. Right. And there's a lot of things that need to be done, but I think as obstetrician or as providers in general, we think because we're educated, we dedicated so much time to serving people that we're above having faults or having biases. And I think that's simply not true. Until we are able to understand that and recognize it and understand what role we play, I don't care what SMFM puts out, what ACOG puts out about the stats, it's not going to change.
Right.
Would you agree?
I agree. And again,
Yeah.
I know that the point of this discussion was for anesthesia, but I'll just say this. I have an MBA and one of my areas of focus was organizational behavior. And so when
Mm-hmm.
you start talking about culture and diversity,
Yeah.
these are things that I'm obviously very much so aware of because I've trained in them. And unfortunately, when we go to med school or we go to, PA school or nursing, we don't have a lot of experience with these subject matters, this quote unquote softer subjects. It's a lot of objective data, a lot of, analytical reasoning and, hard science. But when it comes to actually going out there and working as teams and or, existing in this ecosystem that is healthcare, we don't understand how to deal with various different groups of individuals because we're not trained to, right?
Yeah.
We have to be trained to do these
Mm-hmm.
things. You can't expect someone to be thrown out into the community and just
Mm-hmm.
know how to work with any and every, person that exists out there. We all have different backgrounds. We all have different things that we experience. We all have our own personal biases. And like you said, until we actually have cultural sensitivity training, we check
Mm-hmm.
these biases, we go through implicit bias. These things aren't
Mm-hmm.
comfortable. They
Yeah,
make us
it is.
vulnerable.
Mm-hmm.
It makes you peel down a layer
Mm-hmm.
and you're vulnerable. And a lot of people
Mm-hmm.
don't like feeling vulnerable
Yep.
because we like to be in control.
Mm-hmm.
But in order for us to really treat people well, we have to open up that door and allow for us to, have that vulnerability so that we can actually truly have
Mm-hmm.
a better, not just treat our patients better, but actually have a better system. That's how we can improve the healthcare system. That's how we have better working relationships. You know what I mean? Like when we actually can understand what's going on with someone. Like last year was a heavy year. I don't want to go into it
Yeah.
too much, but like Mara and myself, I see she's in the chat. Like 2020 wasn't a normal
Yeah.
year for anybody. It definitely wasn't a normal year for Black and brown folks, whether
Yeah.
you're a doctor or not. It
Mm-hmm.
was a hell of a year.
Mm-hmm.
Thank God we got through it. But at the
Yeah.
same time,
Yeah.
like, like there are certain things that plagued me or bothered me about last year that I'm the only one that knew about because I was the only Black person, Black male
Yeah.
in my entire department, right?
Mm-hmm.
And so like when you
Yeah.
don't have an ability to communicate these things out with people,
Yeah.
it makes it more challenging. So we're not expecting people to have, a perfect understanding of
Yeah.
what everyone is going through. All we're saying is be present with folks,
Mm-hmm.
open up that door, have the opportunity to understand what someone else is going through, try and view things from their vantage point so that we
Mm-hmm.
can actually, really truly reach this equitable state that we're hoping for.
For those,
And it takes policy
yes,
change too.
change. Yes, it
Yeah,
does.
yeah.
And there,
That inside of us is one component. The outside
yes,
component is policy change and
yes,
systemic
absolutely.
change for sure.
Mm-hmm. And for those of you that are listening that might think that what we're saying has nothing to do with the topic at hand, it actually does.
It does.
For the reasons that Dr. Patton were the root of why Black and brown individuals are perceived to not have the same pain needs as myself. This has been hundreds of years in the making, and this is still happening on the labor and delivery floors. Well, I can use that. I'm sure it's not just labor and delivery. It's anybody that needs pain control for whatever reason. But labor and delivery, why is that important? Because you have a Black or brown individual who's in the most vulnerable point of their time or their life, having a child and in pain, and you don't want their needs to not be heard because they're Black or brown. So this is a very applicable topic, because we're talking about pain control, and we have to understand where this comes from, and we have to understand why. You're an obstetrician. If any obstetricians that are listening are going to listen, you walk into your room, your Black or brown individual says, "I don't want an epidural." Is it because she really doesn't want it, or is she scared?
Right.
And does she feel like you're not going to advocate for her? Does she feel like there's nobody there to advocate for her? Right?
Yep. And that's what I'm saying right now in terms of the vaccines. If someone says no, why? Like, don't just write it off as in, well, they're not going to get it. Mm-hmm. Well, why is that? Why are Black and brown folks maybe adverse to getting it? Why are Black and brown folks adverse to getting epidurals? And not just that, I just want to say one quick thing. Yeah. Mental pain, emotional pain, psychological pain manifest as physical pain, right? So part of the reason why we're going to go into it, the nitrous oxide, option is an option for pain management in this space. Labor and delivery, nitrous oxide is a gas that we deliver in anesthesia, usually in combination with another gas, but we can use that to help with general anesthesia. But we also now are using it in some areas for labor and delivery. It's because not just that it actually has an analgesic property where it may actually reduce the pain, but it actually reduces your awareness to it, right? Like you're just not as concerned, quote unquote,
concerned
with the pain
with it.
Yes. So that helps. So when you actually have psychosocial stressors, you have emotional pain, you have trauma, that can manifest as physical pain. It can make your entire experience, whether it be labor and delivery, surgical, whatever it may be, it can make your experience that much more worse. So we do have to address these things, because if we can address those things, then maybe we don't need to rely so heavily on pain medicine, right?
Well, and the other thing is, you can't assume a patient's being difficult.
Correct.
She's just being difficult. And and nobody really sits down and talks, where is this coming from? And
Right.
I found several instances where I've been told, she's being difficult and she doesn't want an epidural, and I know she's in pain. I'll sit down and I sit down and I talk to her, and I
Right.
say, what are you scared of? What is,
Right.
and you will find out things that have really nothing to do with why she's there.
Right.
It's something else that's in the room with her at this time, which is
Right.
causing the things that you're saying. So, again, you have vulnerability, you have distrust, you have, not answering questions, not taking the time, you have history, all in that room together while someone's delivering a baby. And
Right.
unless you take the time to find out where this is coming from, you're just going to have, someone that's being neglected and not getting what they need. So
Right.
I appreciate this talk.
Yeah.
I think, I don't know, this is where we decide
No,
wanted to go, but I
it's a
think
good tangent. It's very much so. It's very much so important. Yeah.
it is important. So, we'll stop right there. I'm going to ask you a few more questions.
Sure.
The spinal is typically done for a C-section because you want complete blockage, because it is a surgical, you're doing a surgery. You don't want them to feel cutting. But I will say, and I always tell patients, that you might feel your belly moving.
Correct.
You might feel your body moving, and it feels very weird. But you should not feel sharp pain, right?
Correct.
So sometimes the spinal might fail, but we do safeguards to try to make sure that we have what we call a level and we have a good blockade before we proceed. Can you talk a little bit more about that?
Yeah. So usually, again, if it's not an emergency where we actually are doing a scheduled C-section, we have a lot more time in terms of trying to ensure that the spinals work. And even so, we don't cut. If we're not comfortable with the epidural or we're not comfortable with the spinal, we'll just do a GA. Even though we try to avoid doing general anesthesia. General anesthesia. We will just go ahead and put you under general anesthesia because the last thing we want is for you to have a traumatic experience. Okay. Now, God forbid, there's some sort of crazy situation that is an absolute emergency where we have to get baby out. Life-saving situation. It could be completely different. But I'm talking about like our urgent or scheduled non-urgent emergent situations. For the spinal, we're trying to get a level of T4, which is up to basically the nipple line. And the reason for that is because there's a lot of stretching and pulling that's involved. Even though the incision is lower in the belly, there's a lot of stretching and pulling. And there's also, cutting of visceral organs and whatnot, the uterus. And so we're trying to ensure that there's an adequate enough level so that you're not feeling that sharp pain. Again, sometimes the spinals fail because we're not actually in the spinal canal when we inject the medication, or even though we're seeing the medicine come out through that needle, or sorry, the CSF, the cerebral spinal fluid, come out through the needle that reassures us that we're in the right space. Once we inject it in, it doesn't get deposited in. That can happen. And there's a few other situations, but usually if the spinal is not working and we put the spinal in, and let's say the OB goes ahead and tests the belly, usually what happens, you get the instrument and you start pulling and tugging on the belly. We're not cutting, we're just pulling and tugging to see if you're feeling any discomfort. If we take, because I'm on the other side of the curtain, if you tell me I'm testing, and I'm looking and mom's not wincing or you're not saying ouch, you're not complaining, then we'll go ahead and start. If for whatever reason there's any sense that you may be feeling some discomfort, we either place an epidural if we can and slowly bolus up the epidural because we don't want to have a high spinal, or we'll just do a general anesthetic to keep you safe and comfortable. But as mentioned, it is totally normal to feel pressure. I say that having never had this experience, and I'll never have this experience, right? So I say that, you say that, but you've never had this kind of pressure. You're right. I've never had this kind of pressure. But, as we're pulling and tugging and pushing, for example, we could be pushing up on the diaphragm. That can cause referred pain to either shoulders. That's totally normal. People may say that they're having a hard time breathing, that they have pain in their chest. Again, we're pushing and pulling on things, and that can give you a sensation of having a difficult time breathing. But we're checking all your vital signs. Check your heart rate, your blood pressure, your pulse oximetry, end-tidal CO2, everything. We check it all to make sure that obviously we're keeping you safe and comfortable. That pressure that you're feeling is actually normal. But what we don't want is that sharp incisional pain is what we're trying to avoid. And if we get any sense that you're feeling that, whether by testing and or if they start cutting and you feel some pain, then we ask them to stop so that we can get you safe and comfortable.
So the big question is, I get asked this all the time, why can't I don't want to feel anything, I don't want to see anything, I just want a general anesthesia. And the reason for that is, if we put you to sleep, we're putting baby to sleep. And what happens is, once you become under general anesthesia and you're out, we have to move a lot quicker. There's more potential for more blood loss because we're moving quicker, because we have to get baby out quicker so that the baby's born the least depressed as possible. And even as quick as we go, sometimes the baby still might be born and need a little help breathing. So the whole purpose of why we don't just do general anesthesia on everybody is because we don't want to put the baby to sleep or make the baby depressed or sleepy. So that's why we prefer to do the spinal anesthesia on people who are having elective C-sections or repeat C-sections, or an epidural and then dose the epidural up if you needed a C-section for whatever reason. We prefer to keep mom awake because mom awake means baby's awake.
Yeah.
So, but if we need a general for whatever reason, we can convert to the general. Yes.
Yeah, and I'll take it 2 steps further. We keep mom awake so that we can actually do skin to skin, so that you can have a pleasurable experience, right? Like we want to see the tears flowing. We want to see you happy. We want to see you taking pictures with your baby. We want to keep you awake because obviously, you know, these are all things that help, not just in terms of you being safe and comfortable, but they actually help with decreasing bleeding. It helps with, you know, your bonding with baby. You know, obviously there's proven benefit there for both mom and baby as soon as possible. But one of the big things for us from anesthesia side, we are very much so concerned about the baby in terms of what anesthetics or what drugs could be potentially passed to the baby and whether or not baby's going to come out breathing okay, or APGAR scores or whatever it may be. We actually are very concerned about the airway anatomy.
Yes.
That is an extremely hyperdynamic thing. You can have a normal airway anatomy at the beginning of your laboring process, at the beginning of first stage. And then as you approach the end of your second stage or in the middle of the second stage, all of a sudden your airway exam is changed.
Different.
So that we're very concerned that it may be a challenge to actually safely secure your airway. The actual rate of failed intubations is still low, but it's higher than the normal, the average patient population when we're comparing obstetric labor and delivery patients to, you know, the average, intubations out there. So the average patient out there. So we don't want to manipulate the airway, or we don't want to go into the airway if we don't have to, because of the fact that it could be a challenge to intubate mom, but it also can be a problem in terms of, again, wanting to ensure that we're not, passing our baby's not getting some of these anesthetics that we're giving mom. So we'll usually avoid opiates. We usually just use gas, propofol, and we give the opiates once baby is out. We'll give some Duromorph or some morphine once the baby is out to help with the post-op pain for postpartum period. But even so, like you mentioned, some of the anesthesia gases and whatnot will obviously pass to the baby, as well.
I wanted to talk briefly as well, skin to skin, some hospitals allow it, some don't. There is a push to do it, even after a C-section. And you can talk to your doctor about that. If there's some reason why, if you have a C-section, you can't, there also is benefit now. A new study just came out that having skin to skin with the partner until you can is also beneficial. So that's also something that can be done, because there's plenty of times I work in high risk OB. So it's not always feasible that the mom can do skin to skin right away for whatever reason. But partners being able to do that can also be arranged. So it's something that you're interested in, talk to your obstetrician about that. The other thing I wanted to touch on is, the natural birth, which this talk is in no way saying, we advocate for you to get pain control or epidural or whatever. You do what you want to do. And there's many women or many patients who have gone through labor completely naturally, and that's great. If there is a tear, and this is my personal approach, if you end up tearing during labor and delivery and I can't get a good exposure, if I can't see because of the bleeding, doing the local anesthesia is not always possible, because if it's a big enough tear and you're bleeding enough, I can inject local anesthesia all day long. It's not going to numb you enough. And in that case, I might need to call Dr. Patton and say, I have to take her to the OR. She needs to have a repair, and I want to do it in the OR under anesthesia. So even if you went through your labor without having an epidural or a spinal, you may need one because of the tear that you have. And I just think people should be aware of that, and that's fine. We can do that. But I'm sure you guys do that a lot too when, they've been through labor without any medication. They need it for repair of the tear. Yep.
And usually people, once baby's out and baby's on mom or the laboring individual, it's just a situation where you become really indifferent. It's still your choice, but I've seen it oftentimes where it's just like, whatever needs to be done.
They're fine.
Baby now, I'm so happy, I don't mind. It's usually not as maybe much of a concern as it is before, but it's still your choice. We obviously think it's the best option, again, because it allows us to minimize the need for, having to go down the route of general anesthesia,
Yes.
and we want to keep you awake and all that stuff. And so, we do it because, and it actually requires less, because you only really need to cover, again, those sacral roots. So
Yes.
it requires less amount of local and opiate. But yeah, we do it to ensure your safety and comfort, and to make it as pleasurable as an experience for you as possible.
Yeah, if the tear is amenable to having local anesthesia, I can do that. That means I just put it in a syringe, I numb up the area, and I repair.
You repair,
but
right?
But if I can't, because the bleeding's too much, or the tear's too involved, or I can't see because maybe the tears were inside, then I'm going to take you to the OR to have that done safely and where you're going to be more comfortable.
Yeah.
In that case, you could do like what we call a saddle block, and that's where it's kind of like getting a spinal that just numbs down lower, and that you won't feel the repair.
Yeah.
One question I also got a lot is, I hear a lot about people getting epidurals experiencing back pain for life.
Yeah.
Is there anything to that?
No. So we've looked at this. I mean, obviously, again, we're not going to do a prospective randomized controlled trial study with this, but like, we've looked at the data, and actually let me see here. I have the number. The occurrence rate of any kind of severe back pain or nerve damage is 1 in 250,000. Very, very, very rare. Usually people have some discomfort at the insertion site where the Tui needle is going in. That's totally normal, because you're actually going in and you're going through muscle and nerves. And so, like, you may have some pain for maybe hours, or discomfort for hours to days, but to have anything long-term or permanent, especially, concerns for paralysis and all this stuff, we just don't see it. And you can obviously speak on this in terms of the laboring process. There are many different reasons for why you may have low back discomfort or pain in various different areas of the body.
What I was going to say.
It could be the side of the hips or the side of the legs, because you're in the saddle, and it could be the low back. I mean, baby's obviously pushing it. I mean, there's so many things.
It's exactly what I was going to say. I think a lot of times the epidural gets blamed, when in reality it's because of the stress of pregnancy on your musculoskeletal system. I delivered twins 4 years ago. I still have low back pain, and I had a spinal, and I ended up having to have general, and it's just because my back is kind of jacked up a little bit from carrying those twins. So, it may not necessarily be from the epidural. It's likely just, especially if you've had multiple pregnancies, it could be that you have some lower back issues from that. In which case, maybe a physical therapist might help getting evaluated to see if there's something that can be done to help strengthen your back if you're having some kind of chronic pain issue. So, I'm not saying it can't ever happen. Dr. Patton just gave you the stats. Of course, there is a small chance that it could, but it's more than likely due to something else. That could just mean that you need to see a physical therapist and do some core strengthening, some muscle strengthening to help your lower back. I know that's what I need to do, actually.
Yeah.
So
yeah,
I do.
And I'm glad you mentioned that, because I mean, obviously there's folks who want to know what are some of the non-pharmacological options as well. I mean, there are many different options that we use actually with the pharmacological options, whether it be, massage therapy, you may have a doula, or in some instances you might be able to have a midwife. You just having someone there to hold your hand or to confide with or go through this process with. It could be, ice, baths, showers, acupuncture. There's all kind of acupressure, so all kind of different things that we can do along with the pharmacological. It's not that saying that one replaces the other, but the actual non-pharmacological options, they do have a place as well. And if those are things that you're interested in, you can speak to your OB and the anesthesiologist as well, and we can figure out if it's feasible to have those done. It's a little bit tougher now because of COVID, obviously.
Yeah.
But non-COVID times, there are many times where we've seen people come in and folks are getting massages and any number of things, and that all helps with the experience as well.
Well, we only have a few more minutes left, but I wanted to close by saying that as far as pain control in labor and delivery, I think that a couple of things, and having delivered a gazillion babies myself, I think the pearls that I have are to be willing to change your mind. Meaning, if you had an idea of having an unmedicated birth, be willing to change your mind and get that epidural and not feel bad about it, or vice versa. If you had a plan I don't want to feel anything, but you, for whatever reason, ended up with a very fast labor and you show up at 8 centimeters, don't panic and think you can't do it. I've seen that as well. I got to have the epidural, and there's not enough time, and all of a sudden you could just see the panic just,
Right.
And you know what? We can coach you through this. You can do it. Even though it may not have been your plan. So either way, just being amenable to the unplanned and knowing that the OB is there, anesthesia is there to help you through it. And at the end of the day, ultimately, it's your decision. It's
Your
not your
decision.
support person's decision. It's
Yep.
not your doctor's decision.
Not
Now,
your mom, your grandmother,
not your mom, or
your auntie
now,
from 3 generations
right,
before that told
because
everyone not to do
not
it.
to do it. But I will also say there are some situations, and I can do another talk on this, and you may too, where I recommend it. Where I'm going to recommend.
Yes.
I will recommend you.
Yes.
You need the epidural.
Yes.
For X, Y, and Z.
Yes.
And there are some medical conditions, some scenarios where we do have strong opinions about having an epidural. And I'll tell you one of them, and I'll stop with that.